I'm just curious, out of the crowd, how many of you guys are coaches? Big number. This talk is basically aimed at you. This is the nagging talk, which can be summed up in basically one sentence, which is let kids be kids here, all right? So I get to talk about overuse injuries, and this is not going to be as sexy or as impressive as Dan's talk, but it's a pretty important issue in orthopedics right now. I don't know many or really any of you, so just so you know who I am, I'm a local guy. I grew up in Marcellus. I went off to college where I was primarily a lacrosse player. All the guys that are talking today, we take care of the majority of sports teams in town. Dan is the head physician for Lemoyne. My big jobs right now, in addition to the high schools, are SU football and the pro soccer team and OCC here in town. And at the end, I'm going to put up my email address. I'll take a few questions at the end, but I can't stay for the panel because I have to run to practice. So please feel free to contact me later with any questions or any issues you want to just email me directly, or you can get in touch with me through the folks who put this thing together. So anyway, let's talk about why we're here for this talk here. So in general statistics, and I put kids in quotes because we're talking up to the end of high school, and you may or may not consider those 17 and 18-year-olds kids. But if you group those all together, we're talking about at least 50 million folks playing active organized sports right now, and at least 8 to 10 million of those are in school sports, scholastic sports. If you look at the injury rate, there are millions and millions of injuries, sports-related injuries in these kids per year, and a high number of them are what we're going to term overuse injuries, and we'll get into a little bit of what we mean by overuse, but in general we're meaning are caused not by one specific event or one specific mechanism that resulted in the injury. They're pretty evenly distributed across both boys and girls, and it depends a little bit on what sport you're playing, obviously. When you look at these numbers, and these are actually now about 5 or 6 year old numbers, I mean, these are huge numbers of injuries occurring in adolescents and teenagers playing sports, you know, upwards of 3 to 4 million, as we said on that last page. So you say, all right, big deal. Kids have always played sports, kids have always gotten hurt. Why does this need its own talk now? Well, the reason is basically because the types of injuries that we're seeing are shifting. There's a trend from one major group of injury to the second major group of injury, which is going to be the overuse injuries. This doctor here, Lyle McCallie, he's sort of the father of the pediatric sports medicine specialty. He's a physician at Children's Hospital in Boston, and he's gone on record in numerous articles and numerous speeches talking about how his practice has shifted over the years, and you can read this. He says 25 years ago, 10% of the patients he saw were for overuse injuries, where now it's well over 50%. And he kind of boils this down to two different factors that he feels is contributing to this trend. One is the devotion year-round to a single sport, kids doing the same thing month after month after month with no break. And the other is the increased intensity of that training. Not only are they playing the sport, but they're playing it at a higher level with higher demands. They're at tournaments playing multiple games a year, much more intensive playing of that sport. And the same thing is reiterated by another guy you may have heard of, Jimmy Andrews down in Alabama, is probably the most famous orthopedic surgeon in America right now. Same thing. He's seen a multiple-fold increase in the number of overuse injuries he's seen as kids. He talks about those same factors and he gives them a name. He calls that year-round playing the early specialization of kids. And then he calls that maniacal training the professionalism. Basically, they're starting to think they're professionals at age 6 and 8 and 10 and 12, this hyper-intense training and the associated pressure that goes along with it. So when we back up for a second and say, what is an overuse injury? It's pretty obvious, but on a biological level, what an overuse injury is any injury that results from a submaximal force or submaximal stress. It's repetitive loading, repetitive stress on a joint or a bone or a muscle that ultimately results in the injury. And what happens is slowly over time an inflammatory response starts, the inflammatory chemicals accrue, and those inflammatory issues basically can result in slower damage to those structures, bone and muscle and tendon. You get microtrauma at first, doesn't show up on an x-ray, doesn't show up on an MRI, but as that trauma progresses and progresses and progresses, now you get the macro trauma injury that can be visibly seen. Some of the reasons kids may be more prone to overuse injuries than adults is that they are not just small adults. There are some differences between the bodies of kids and the bodies of adults, and Dan did a nice job touching on those already. First of all, they have different injury patterns in terms of the kinds of forces they're exposed to. Second thing is they have different healing responses, sometimes better. They often heal faster than adults. There's certainly a whole different host of concerns in terms of sports participation and careers and lifestyle and the whole thing. There's a lot different psychology with kids versus adults who are still, feeling peer pressure and coach pressure and parent pressure. And another big one that plays a role is that no two kids are alike. You all know that a 13-year-old can be a 5-foot, 90-pound kid, or it can be a 5'10", 225-pound kid. And those kids are thrown into the same league because their age reads the same. Those are two very, very different individuals. On an anatomic level, this is what Dan already talked about here. We already pointed out the growth plate. Kids in general tend to be more bendable versus breakable. They have more elasticity in their muscles and their bones and their tendons. And as I said, they may have a different or a faster healing response, all of which plays a role into how these overuse injuries are ultimately handled. And I did not know Dan was going to put this up, so let this just be even further sort of reiteration or stressing of how growth plates are a major issue in pediatric bones. You can see those growth plates on the left, which aren't present on that right, and that is a specific area of injury, not only acute injuries like fractures he talked about, but also in the overuse injuries I'm going to mention here. So I tried to break this down into 3 different slides about what kind of things contribute to overuse injuries. And basically the first ones are the intrinsic things native to that kid or that patient or that player that you have no control over but you need to be aware of. These are mostly anatomic things. Their ligaments are stronger than bones, so they're going to be susceptible to bony injuries. Nothing you can do about that. That sort of plays into the type of injury that Dr. Narowski talked about with the ACL avulsing. Instead of the ligament tearing, it pulls a little piece of bone off. That's because in a lot of places the ligaments can be stronger than the bones. We've already hit on the growth plates. Big thing that happens in kids during their growth is that things don't happen equally. They grow from the bones. The muscle mass increases very rapidly. Remember, bones are growing in length, meters or inches or feet. Their muscles are growing in volume, so that's a discrepant growth right there, and then everything else has to play catch up. All those tendons and ligaments and everything has to sort of respond and stretch and increase, and so it leaves them with significant imbalances at certain points during their childhood and during their growth phases. So those things you can't do anything about. It's going to happen, but you should be aware of them. The next step is things you may or may not be able to affect, but it's probably in most kids worth a try. Prior injury, obviously if you prevent the injury the first time, they're going to be less likely to get another injury down the road. You can, to some degree, control their conditioning and make sure they're prepared for practice or games or whatever they have coming up. Nutrition, psychological aspects in play there, but you can certainly do some things to try to affect their nutrition and their hydration. Some of their psychological factors can be affected in terms of how much pressure they're feeling from outside sources, intrinsic psychological issues like self-esteem, maturity level. And then at the bottom there, to some degree, you may be able to affect some of the anatomic things. We all know that, for instance, foot posture and foot structure puts people at risk of stress injuries to the tibia, shin splints, stress fractures, increases the risk of anterior knee pain. Some of those things can be fairly easily addressed through things like orthotics, proper footwear, and there is a table out here for our SOS shop, which carries a lot of things, which has a couple very good staff members who are good at fitting and adjusting footwear and orthotics and other braces and things that may help some of the malalignment issues you see in these kids. This slide is probably the most important because these are the ones you can definitely affect, and this is what the bulk of this talk is about. You can affect how quickly and intensely their training progresses. You can affect how much rest they have between training periods. You can address the equipment and footwear issues. You can address their technique, whether it's throwing technique or running technique. You can address some things in terms of where they're practicing, and you can certainly control how much pressure they're feeling from coaches and parents. This is where efforts need to be focused right here on these overuse injuries. So the purpose of this talk is not really to talk a lot about specific injuries, but these are things that Dan and I and the next 2 doctors who are going to talk here see day in and day out. These are all common injuries we see all the time. Starting at the shoulder and elbow, we see a lot of stuff related to growth plates, little leaguer's shoulder and little leaguer's elbow. These are basically early stress injuries to the growth plates at the top of the humerus and at the elbow, distal end of the humerus. We see inflammation around the attachments of ligaments to bones and tendons to bones. These are just fancy words. Epicondylitis is basically tennis elbow or golfer's elbow. We actually can see rotator cuff issues even in these young kids, the throwers, javelin, football, baseball. Instability does not necessarily require a fall and dislocate your shoulder. We can see micro instability from time. And then OCD, which Dan already talked about. We're not 100% sure, but the leading theory is that this may be a micro trauma issue that develops from sort of repetitive trauma, repetitive impact, ultimately affecting the blood supply to an area of bone and cartilage. So, this is actually a case I was involved with back in residency many years ago, but here's a 13-year-old who actually needed surgery for a rotator cuff tear. He was a pitcher that was pitching 2 games a week plus practice almost every day, and showed up not with just inflammation in his rotator cuff, he had a tear that required surgery. So, this is unusual, but it's not impossible. When you get into specifics about things you should know, anybody who's involved with baseball should be familiar with the throwing recommendations that are put out by various societies, and I'll actually give you some sources for these later. You don't need to know the specifics by heart, but you should know that there are very well-established guidelines for how much a thrower should be throwing. It obviously progresses by age. The other thing that happens is they talk about rest days. There's also some evidence, controversial, but some evidence about whether certain pitches put more stress on the shoulder than others. And for a while, the sort of party line, although it may be changing, is that at very early ages, fastballs and changeups may be most appropriate, with curveballs and sliders really only being introduced later. Those mechanisms may put more stress on the shoulder than the fastball and the changeup. And then when we talked about mechanics being something you can control, there's no doubt that sidearm throwers put greater stress on their shoulder and their elbow than overhead throwers. That's a thing that coaches can help work on, fixing those mechanics. And this is a different source. They break it down a little bit differently. They talk about total pitch numbers per day and whatnot, but these things are out there. And if you're ever interested in finding out where they come from, contact me. Write down the sources at the end of the talk. Anybody involved with these types of athletes who are coaching baseball in the spring, they should know about this stuff. Similar things happen for other overhead athletes, swimming, volleyball, that kind of thing. There are guidelines here as well. It goes by age. Here's the swimmer's guidelines, how much stroke they're working on, how many sessions, how much time per week. Leg issues. Dr. Narowski talked on some of these as well. We hit the growth plate issues and the tendon insertion issues like the Osgood-Schlatter. Syndig-Larsen-Johansson is basically the exact same thing as Osgood-Schlatter, but it happens at the top end of the kneecap tendon instead of the bottom end where it attaches to the tibia. We talked already about shin splints, which are now technically called medial tibial stress syndrome, a little bit more technical name, which can progress untreated to real stress fractures. And in a worst case scenario, you get that Louisville basketball player from a few years ago, his tibia snapped in two. I've had a couple football players who have ignored shin splints until their leg broke in the middle of a game. I mean, these can be serious things. We got OCD of the knee as well here. Anterior knee pain, big one, whether it's patellar tendonitis, whether it's that Osgood-Schlatter, whether it's patellofemoral pain, which is just basically an inflammation of the cartilage under the kneecap. All these things can be tied into overuse and to inadequate rest period, inadequate technique. For those of your guys that are running, and this doesn't just have to be the cross-country coaches in the room, football coaches who are conditioning in preseason, basketball coaches, whatever the case may be, there are definitive guidelines out there about how much running kids should be doing, how much rest day they should have to do. And the other big thing you should know about, particularly in terms of running, is this rule of tens. In general, you don't want to increase the intensity, the duration, or the frequency of your running by any more than about 10% a week or so. That is thought to be a safe level to which muscle and bone and tendons can accommodate and react appropriately. Strength training is a big one. No matter what sport you're coaching, your kids are probably in the weight room certain days a week. There's a lot of weightlifting injuries out there, a lot of ER visits per year. Most of them are happening when there's no adult in the room making sure they're lifting safely. So number one thing to do is have a supervisor or a spotter in there working. A lot of these aren't big deals. They're muscle strains that are going to resolve with time and ice and rest and all the normal stuff. A lot of them are in the low back, but not always. There's certainly catastrophic or surgical weightlifting injuries that we see. There was some question for a while whether weightlifting was any good or healthy for young kids. Most of the studies do now show that a well-structured weightlifting program, even for young kids, can be beneficial, that they do get stronger. One thing you need to remember, and you need to remind your kids, that until skeletal maturity, they're not typically going to see a lot of muscle bulk gains. These kids shouldn't be lifting to get big at 12 years old or 13 years old. They're going to get stronger, but they're not going to get bigger, and that shouldn't be their goal. There was some question at some point whether weightlifting stunted growth. Did that increase stress across the joints and across the growth plate actually affect the growth of the bones? That does not appear to have panned out, at least by what we know so far. And there was also a question about whether weightlifting leads you to tight muscles. You get inflexible, you get higher injury rates, the whole deal. As long as you're doing a good flexibility program and stretching with your weightlifting regimen, that's probably not a great concern either. So net result on that is that weightlifting's okay, but you got to remember those factors. You got to use proper technique, you got to have proper rest days, you got to make sure you're using proper equipment and having spotters. All that should limit your number of weightlifting injuries. This was a good place for me to put in just a brief mention about steroids. That's not the point of this talk, obviously, but steroids increase your rates of overuse injuries. They weaken tendons, they weaken ligaments. And even though you might say, oh, that's not running around my school, it turns out they really are. You know, I have sometimes hard time believing these statistics too, but there have been enough surveys done that they're out there and they're in your school if your kids want them. Steroids are basically derivatives of the sex hormones. They're all related to testosterone, which is also related to estrogen. These are sex hormones. And the way they work is they basically help you retain protein in your diet and they help build muscle mass. And this survey is a few years old, but you know, these are impressive numbers. 12% of males in high school have taken steroids. A couple percent of girls. I mean, it can be hard to digest, but it's been replicated enough times that it's hard to deny at this point. And in terms of lecturing your kids on there, you football coaches out there, if you need to give a kid a talk, they're not going to be terribly scared when you tell them that, hey, you know, steroids are going to increase your risks of muscle pulls or, you know, heart disease 40 years down the road. But the boys aren't going to like when you tell them that it's going to make their balls shrink or their boobs grow. And the girls aren't going to like when you tell them that it's going to make them grow a mustache. That's where you're going to scare these kids. So when you summarize all this stuff up, the AAP is American Academy of Pediatrics. You know, if you kind of want to boil this down into a few bullet points, probably the very young kids, 5 to 6 or younger, really shouldn't be playing competitive sports. They want to get out and kick the soccer ball around. You've got a town league, that's fine, but there should be no emphasis on winning or any sort of pressure like that. As these kids get older and start formally conditioning for sports, you got to make sure you've got a mix of endurance, you got a mix of stretching, you got a mix of strengthening. Always be doing warm-up and cool-down exercises. We can have the stretching debate as to which is more important and whether it's important at all, but certainly maintaining good muscle flexibility is not going to hurt you, and if anything is going to decrease your injury risk. Always do a gradual, slow, and steady increase in any sort of training, whether it's strengthening or running or throwing, that 10% rule we talked about. There are national guidelines not only for throwing and running, but there are others I'll get to in just a second. Follow proper nutrition, proper hydration, make sure the equipment is appropriate and well-fitting. Cross-train, cross-train, cross-train. You want to get away from that year-round specialization. I don't know what happened when I was a kid. We all played, me and every one of my friends played 3 sports a year, and all of them in the summer. You were doing something different every day. Those are different muscle groups being exercised. Those are different stresses on the joints every day. And then when it comes down to it, kids start complaining. No child should be playing through pain. So in terms of numbers you can write down and take home with you, probably immature kids, and we're talking, as we said, those growth plates closing in boys at somewhere around 14 to 16, girls a couple of years younger than that, they probably shouldn't be training any more than 18 to 20 hours per week, and they should have a set rest period per year of a couple months where they're either doing something else or doing nothing, and they have a chance for their muscles to rehabilitate and to rest. That 10% rule is the third time I think I've had it up there. And then in terms of getting these kids training, you're going to gradually advance them psychologically and physically with first working on technique and mechanics. Then you work on the actual skills and power and strength. And in young kids, again, be very careful with objective evidence of performance. You know, young kids should not be timed or radar gunned or have, you know, weight charts in the weight room showing how much they lifted last week compared to this week. It adds an undue pressure and an undue influence here. When do you start to get worried about these overuse injuries? It's not going to be the kid who walks out with his kneecap sitting over on the side of his knee. It's not going to be the guy who comes in with his arm bent in two. Those things are relatively easy to recognize that it needs a physician. One of the first things you're going to see is just a very subtle decrease in their performance, whether it's their throwing speed, whether it's their arm distance for your quarterback, whether it's their time through the cross-country trail. The performance starts to go down. That can manifest in a lot of ways, whether it's something objective like that, whether they're not meeting the training goals that everybody else is meeting. It may be psychological. They're coming late to practice. They seem less interested. They seem less motivated to perform. When do you get them in to see us? Controversial, but I think these are all relatively inarguable factors. Kids unable to play for more than a few days. They don't bounce back after the usual rest and ice and ibuprofen for a couple days, 3 days, 4 days. Significant decreases in performance. Limps or sudden inability to bear weight on that leg. They've been dealing with this pain and now it's gotten dramatically worse to the point where they have trouble putting weight on their leg or their ankle or their knee. Swelling like Dr. Narowski talked about, or objective loss of motion in a joint. Any visible deformity is going to be obvious, and then we can argue about what severe pain is, but it's one of those things where you know it when you see it, and you know your kids and you know who's the whiner and who's not. Some of the places you coaches may want to take a peek at. First is the National Center for Sports Safety. The website is up there. Again, I'm happy to email this to anybody. But these are national sports foundations that have online education tools and cheat sheets and recommendations in terms of throwing and running and swimming and those kind of things. Another one is an orthopedic specific program called the Stop Sports Injuries, which is basically addressing trauma and overuse prevention. Has the support of lots and lots of major national medical organizations. They've got these same sort of cheat sheets and guidelines. There's a great book out there by Dr. Andrews about how to prevent these injuries. Probably should be required reading for anybody coaching kids younger than 18. These injury sheets, this is just an example. They've got them for every different sport. This is the gymnastics one. This is the football one. There's now 25 or 30 of these on that Stop Sports Injuries website, which would be a good thing to look up at some point. And you get through all of this and you talk to your kids and they don't care. They want to be the best. They want that scholarship. They're not going to listen to much of what I said here. But you can actually go out there and find many, many sources online from coaches and former high-level players, all talking about the value of being that three-sport athlete. You look at this list. I spent 6 minutes looking up cross-training online. Coaches, players, Olympic athletes, all talking about how valuable it was to them to be a multi-sport athlete, to have different athletic skills. You want that kid and the coaches want that kid who is across the board good. And that should be their motivation. I'm going to stop here. I'm going to throw my email address up there for a few minutes so anybody needs it. I'm going to take a few questions now because, as I said, I do have to run for another event in a couple minutes. Any questions? All good. Thanks for coming, guys.